Okay. Thanks, Paul. Karen. For those of you who don't know me, my name is Jim Lewis. I'm a respirologist based at St. Joe's. And I've done research pretty much all my life, focused on surfactant. And for those of you that don't know what surfactant is, it's the lining of our lung, the inner lining of our lung that we all have to allow us to breathe without effort. It actually is responsible for having very compliant lungs so that we don't really have the need to work to breathe. The real use of surfactant over the last 30 years, and it's been 30, 35 years now, is for preterm babies that are born without surfactant because their type 2 cells in their lungs are immature. So surfactant is made in the type 2 cells that line the lung. It's secreted and spreads along the inner coating of the lung to allow for breathing without effort. If babies are born premature, they are now routinely given surfactant exogenously, so instilled into their lung. And the surfactant that they get is called BLESS. It's bovine lipid extract surfactant. So in fact, all neonates in Canada get BLESS, and it's made right here in London. There was a couple of graduate students in biochemistry that worked with a guy named Fred Posmeyer, who is a scientist that discovered surfactant proteins. And these grad students decided to make their own surfactant, isolated from cow lungs at an abattoir. They wash out cow lungs, they purify it, and it comes out at the end of the day as a milky white liquid in small 5 ml vials that obviously are appropriate for preterm babies. When I got interested in surfactant, I was actually doing ICU here in London in the mid-'80s, and decided to train and did my fellowship in California with a neonatologist who was an expert in surfactant lung development. And my research focused on mimicking models of ARDS or lung injury. And I'm sure you're all familiar with ARDS. It's a bilateral edema in the lung, non-cardiac edema, that is due to inflammation and can result as a cause of sepsis or a complication of sepsis or trauma or aspiration or pneumonia that gets quite severe. So what I did was various models, animal models of lung injury, gave surfactant in various ways, looked at aerosolizing it, instilling it, giving it through a bronchoscope. And eventually we went to clinical trials. And in fact, about 15 to 20 years ago, about 15 years ago, we did a multinational trial involving about 500 patients, giving them exogenous surfactant into their lungs when they were diagnosed with ARDS. And overall mortality wasn't different. That's why it's not used routinely. But the subgroup analysis showed that patients that had direct injuries, and in some parts of the world that was from near drowning or aspiration or pneumonia, they did particularly well. So unfortunately, these studies are obviously very expensive, and the surfactant we used was not a bovine extract surfactant. It was a synthetic surfactant made in Germany. And the company decided not to make it anymore, and therefore it hasn't been used routinely. But with COVID, obviously it's a lung injury due to the COVID virus that attacks type 2 cells. And although we don't have evidence that surfactant is abnormal in patients with COVID-induced pneumonia, we do have lots of evidence in patients with ARDS that surfactant is abnormal, and as I mentioned, works in direct lung injuries. So we decided to do a pilot study called the LESSCOVID study, London Exogenous Surfactant Study for COVID, assuming that this is like ARDS, and in fact, hoping it was less complicated than ARDS because it mainly involves the lung and it's not multi-system organ failure. Next slide. So as I mentioned, we're doing this because it's an ARDS type of disease. There's lots of inflammation. Patients utilize a lot of resources. Obviously, we've all heard about the resource limitations in the States. Ventilators, they're often ventilated for prolonged periods of time. And the rationale is, as I mentioned, that that COVID attacks type 2 cells, so we assume that surfactant is altered, and certainly in patients with diffuse bilateral airspace disease, some of them have very stiff lungs, so we think it will work. Next slide. So as I mentioned, this surfactant is routinely used in preterm babies. It's safe in preterm babies, obviously saves lives. It's changed neonatal mortality significantly. And in fact, because babies born premature don't have surfactant, when they take a deep breath and exhale, their lungs will collapse and they can't open them up because they don't have the musculature, and they will go on a ventilator. But now surfactant is given even before the first breath in babies who are born less than 32 weeks. We've shown it's abnormal in adults with ARDS. We've shown it's safe. So we did a study, as I mentioned, involving over 500 patients, and there were no significant deleterious effects. And it was particularly effective in those who had direct lung injury. And it's sort of a local story because, again, the company that makes the surfactant that is utilized in these babies is made right here in London. And it's called Bless, and it's a milky white substance. So it's important for compliance. Next slide. We're doing a study, a small study, 10 treated, 10 controls. We're randomizing them, and we basically want to show that it's safe. We've had many people interested in doing a multi-center trial, particularly physicians in Toronto, but we wanted to keep it local for various reasons. One, the material is expensive, and the company we've worked with for many, many years is supplying us with surfactant for this study, free of charge, about $500,000, $600,000 worth of material. And we're targeting patients with COVID-proven respiratory failure who require mechanical ventilation. So right now, we all know there's a second wave. We have several patients at Vic. In fact, at Vic, they've just isolated the 5th floor again as a COVID ward, negative pressure, isolated. And the patients who are sick are on high flow oxygen. And when they get sent to the ICU and are intubated, our study coordinators, Tracy at UH and Eileen at Vic. We haven't had a patient at Vic, but we've had several patients that we've assessed for enrollment. Our exclusion criteria are turning out to be a bit more complicated. Obviously, if they're unstable, if they have active heart failure, or if they're on other inhaled experimental drugs, and there's a study called Safe ICU that Dr. Marat is running, and we want to avoid, if we can, complicating the situation, but these patients are able to receive remdesivir and steroids and even convalescent plasma. So the inclusion criteria are pretty standard. We've found so far that we've excluded patients who require ECMO, and we've had intense discussion whether they should be treated with surfactant, but I'm worried about patients who require ECMO being unstable, and obviously if they don't receive adequate tidal volume to get the material out, because we instill it as a liquid, we worry that it won't be effective. And we've had some problems with accessing surfactant from the pharmacy because of restricted hours. So we're working through those headaches, and Tracy has been great. As I mentioned, we've already treated one patient, randomized to the treatment arm, and the patient tolerated it well. And you'll see how we administer it. It has to be fairly consistently administered in a positional fashion so that we optimize distribution. But we didn't see any deleterious effects, and the patient, I think, is still in the ICU. But obviously, these patients can become quite complicated, and as you know, they're all often very sick. I don't know whether I have any other slides there, Paul. So this basically summarizes what you'll see in the video. We want the patient within 48 hours of intubation. We want the patient sedated so that when we administer this liquid into their lungs, which is well tolerated, we don't want them to cough. and thereby cough up the material. We pre-oxygenate them. We position them right side, then left side, pausing the ventilator, and then administering the tidal volume as previously administered, and obviously give half of it on one side and half to the other. So in total, we usually give about, it'll be about 100 ml. So you can imagine that it only comes in 5 ml vials. The pharmacy has to draw it up into syringes, and we administer it on each side. We monitor them fairly frequently for 24 hours and then daily. And our outcomes are safety, adverse events, oxygenation improvements, compliance improvements, and ultimately, we want to show that they'll require less days on the ventilator, less time in the ICU. This is not powered to show mortality. The idea is to show that it's safe, hopefully show that it is effective, get through the pains of getting the material and administering it, and then ultimately go to a multi-center trial involving other ICUs. So I think that's pretty much it. I don't know whether you want to show the video, Paul. So Tim has been great, the RT that that's helping us at UH, and he has a video on YouTube, I believe, that you're going to see of how exactly we administer the material. I will be administering all the material for safety reasons. The other aspect of safety, obviously, is COVID. We want to make sure we're not breaching this ventilatory circuit, so it's administered through the suction catheter. And we're very careful, and it's unbelievable how complicated it is to get in to see these patients. But obviously, we're hoping to help patients without causing complications to the healthcare workers. Go ahead, Paul.
Yeah, just let me know, is there sound in this video?
Yeah.
Okay. Let me know if you can't hear the sound, I guess.
Okay.
No, we're not hearing the sound.
And there would be sound at this point.
Yeah, Tim should be talking right now.
Give me 1 second then. We'll look back at everybody's beautiful face. Here we go.
So initially, the RT will come in, adjust the FiO2 to 100%, minimum of a half hour pre, oxygenate, and then the patient will be suctioned. And that's that. After the pre-oxygenation and when the surfactant is arrived from pharmacy, the team will
you may suction the patient once, just to be sure that nothing happens during the procedure. The next step would be the administration of some rocuronium or paralytic to paralyze the patient for the procedure. And then finally, once the rocuronium is given and the patient is paralyzed, initial parameters will be recorded. Once the patient is paralyzed, initial recordings done, the team will now reposition the patient and administer the first boluses of surfactant. To do that, we have to turn the patient on their right side while their head's at 45 degrees. Note they are paralyzed, so the trunk and head support are in question, so be careful to support them throughout the whole procedure. The endotracheal tube should be supported. If you guys want to turn, pillow stopped, we lay them on their side, and now they're ready to administer the surfactant. The suction catheter will have a piece of tape placed on it, and this just helps with the seal of the Luer lock syringe. The catheter is now advanced to 40 centimeters. And when When we're ready to administer the surfactant, the ventilator will be put in standby. So standby is activated, and our first syringe full of surfactant. Be sure to depress the button to allow the surfactant to go down the suction catheter. A slow injection is best, so you cause the surfactant not to bubble. The next bolus is surfactant throughout there. And after the surfactant's given, we will follow it with an air bolus to ensure the catheter is clean. The suction catheter is withdrawn out of the tube, and ventilation is resumed. We'll ventilate the patient for 90 seconds, and after 90 seconds, we'll repeat the procedure again on the left side. So, removing the pillow, placing it over there. Once again, you may have to boost the patient to maintain 45 degrees. Launching the head and the trunk, we'll turn them to our left side now. Pillow will be stuffed, tube supported, head is supported, and we'll repeat the procedure again. It is advisable to change the tape. We'll put a new fresh piece of tape on the end of the catheter to ensure the seal. Catheter will be advanced once again to 40 centimeters. And at 40 centimeters, ventilation will be paused and the injections will start. Button is pressed, surfactant is being instilled. Catheter is withdrawn. And the patient will be ventilated for another 90 seconds. After the 90 seconds of ventilation, to force the surfactant down into the left side, the patient will be then turned on their back. Pillow removed, head supported, and the patient will remain in a 45-degree position for the next hour while the RT records parameters Q15 minutes.
As you saw, it's administered through the syringe, via the syringe, and it's a milky white substance. And the nature of the material itself is such that when it hits an airway, it spreads. It's like a detergent. It has low surface tension, and then hopefully gets out to the periphery of the lung and allows us to ventilate with less pressure and obviously improve oxygenation. But surfactant has also been shown to be an anti-inflammatory agent, so hopefully that'll help that part of the disease as well. So any questions or comments would be welcome.
Hi, Jim. It's David.